Very good afternoon to you all. Thank you, Dr. Ish, Dr. Preeti, Dr. Lokesh, for this opportunity to teach you what we have learned and are been learning. So we know little. So whatever we know, I will try to teach you because Dr. Preeti has told me to tell everything, process, interpretation, classification tools, everything in 30 minutes. So I will try to do by taking examples of common scenarios in pediatric endocrine practice, like all these things. Because I know that there are students, so I want it has to be little interactive, especially post lunch. So before we start, we know that for every case now, probably NGS based testing is the first test. But before, on me, okay. Hello. So before we go to NGS, something pre-NGS and basic genetics, which has to be there even if you order NGS-based testing, and exome sequencing becomes only a test for 5,000 rupees. Still, you will need to know. So what is the mode of inheritance seen in this particular pedigree? You should also tell the disease immediately without showing the picture. What did you say? Did somebody say X-linked dominant? So you see more females affected, and then there is no male-to-male transmission, and you can see this type of males as well as females affected. So hypophosphatemic rickets, which is an X-linked disorder. So the message is charting and interpreting pedigree has to be there whether you order NGS-based test or not. Then coming to the diagnosis, many diagnoses of genetic disorders were being done even before there was any testing. So it's not that you need to know mutation. Radiological, clinical-based testing. So what is this? Trident hand, short stature in infant with rhizomelic short stature, and this typical elephant ear type iliac crest, and this is achondroplasia. So why do we want to do molecular testing for this case of achondroplasia? What is the risk of recurrence of achondroplasia in his sibling? Anybody? What would be the risk in his offspring? So if he marries a normal woman and then wants to know whether his child will be having achondroplasia, it is autosomal dominant inheritance. So 50% risk of recurrence. But what about risk in his siblings? Sorry? No risk. Somebody said no risk because his parents are normal. But what it has been observed that sometimes even if the parents are normal, they can have two children with achondroplasia, and that is because one of the parents may be germline mosaic, has some cells with the mutation in the gonads, and hence any family who has one child with achondroplasia and want to find out whether the next pregnancy, if the fetus has achondroplasia or not, we need to do molecular testing because short stature or short long bones will not appear before the third trimester. So if you want early prenatal diagnosis, molecular testing has to be done. Then the risk of recurrence in these siblings would be 1 in 400 if their parents are normal. So all these children, clinically achondroplasia, everybody has the specific single nucleotide change at 1138 nucleotide position. And this makes the testing very easy. You don't have to do NGS at all. You just have to sequence 100 nucleotides around that particular region where you can see A is green peak and G is black peak. So at a particular point, this is a heterozygous, and then you know that this diagnosis is very easy, maybe 1,000, 2,000 rupees. But then there are other allelic disorders of this FGFR3 gene, like lethal skeletal dysplasia, thanatophoric, then mild short stature of hypochondroplasia. They will not have the same mutation. You will have to do other testing. You will have to sequence the whole gene FGFR3. Then coming to some other disorders where There is no single point mutation. Please don't take pictures of the patients because they are like it's a very ethical matter. And these the children with Williams syndrome, they have a very classical phenotype with thick sleeps and periorbital puffing. So if you have seen once, you will always recognize and diagnose. And their test is to detect small microdeletion. That can be done by cytogenetic microarray, or it can be done by very less costly tests like FISH or fluorescence in situ hybridization. But then you have to clinically make the diagnosis. And once you see, you may make the diagnosis. But now there is also an easier face recognition app. Now we know this, how face recognition technology has very much improved. What is this sign for? Digiyatra. So if they can recognize you, they can recognize the faces of those syndromes. So for this some such common syndromes, if you took the photograph in Face to Gene app, then sometimes the diagnosis may be first diagnosis or one of the first 10. But of course, this is not confirmatory. It just gives you some clue. Rather than sending the photograph to Shobha Phadke on email, you can send it, see, and in Face to Gene and find out if you can make diagnosis. Then there are some other disorders like this short stature and rickets. So everybody was treating like rickets, but this boy has a very sparse hair. And this is not rickets, but metaphyseal dysplasia of cartilage hair dysplasia. And this is if you want to find out about this disease and gene, you go to this website called OMIM and find out about the gene and then which are the other diseases caused by gene. So everybody should visit OMIM website at least once a week, because you will be getting at least 1 or 2 patients of monogenic disorders in your OPDs. And there you will find out that the gene for this cartilage hair dysplasia is a non-protein gene. It doesn't produce a protein, but it does only produces an RNA. So a lot of information will be available. And here also there is one common mutation in most of the cases. And again, the diagnosis by Sanger sequencing is easy and cheap, and you don't have to order exome sequencing. So this gene also, now we know NGS-based testing being done. We know that some children with isolated short stature also may have mutation in this particular gene. So so-called idiopathic short stature or familial short stature, some of them may be because of these various genetic causes like multiple epiphyseal dysplasia, hypochondroplasia, Stickler syndrome, and then the carrier parents of NPR2 gene, which causes acromesomelic dysplasia. And some osteogenesis imperfecta cases may have only short stature, hardly any fractures. But if you see the teeth of this particular person, you can immediately make a diagnosis. So clinical acumen has to be there. But now osteogenesis imperfecta, as I said, like those adults without any fractures, while these type of lethal fetuses who die in utero, severe, and so the clinical heterogeneity for osteogenesis imperfecta is vast. And so also the genes, at least 20 genes are known, and they each one may have 50 exons. So what do you do for this? You cannot make a diagnosis that this osteogenesis imperfecta is because of this particular gene out of those 20 genes. So you have to sequence all 20 genes. And which test you will order now? All of us are unanimously should order now next generation based sequencing testing for such. You can send clinical exome, whole exome, and preferably mother, father, and child together should be sent as trio. So what is this whole genome and whole exome? So this is a diagrammatic representation, and these are pink colors are exons and blue are introns. So if you sequence all those exons, that means coding region with their neighboring intronic boundaries, then it becomes exome. And if you sequence the whole genome, it is whole genome. But if you sequence only the genes for osteogenesis imperfecta and maybe some other disorders which have similar presentation because of decreased bone density, then you can order the panel. But now with the cost, and the panel is made last year, and next year again when you are ordering the sample, there is one more gene for osteogenesis imperfecta that may not be there in that panel. So what you have to order preferably is a whole exome sequencing, so that a particular gene which is newly identified, or there is some other disorder like Desbicuous syndrome, which has again decreased bone density. So those disorders will not be missed. Now, when we say that as I said, exome sequencing naturally will be needed for most of the cases, but we have to really decide judiciously, as I told previously. What is the sample preparation and the technique of whole genome sequencing? So it sequences by synthesis. So it will make DNA into pieces, and those pieces are anchored to the segments on the chip, and they get sequenced, and this during sequencing synthesis they get sequenced. So you see this YouTube video of Illumina, and that will help in getting you understanding about the principle of whole next generation sequencing. Then what happens? You have the data of sequences of all those fragments, thousands and thousands of fragments. These fragments are then attached, or they are compared to the sequence of whole genome or whole exome, what is we know of. And what we know of that particular reference genome is just a genome of one individual. And naturally, everybody, one of us has so many variations. We look different. So every 500 nucleotides, there will be one change. So we really don't know which are the normal ones and which are causing diseases. So what this data finally will give by comparison of reference genome, which are these variations and at what places. So you will get only that information. You will not get the disease causing variation. But this particular technology has now confirmed and made all those genetic disorders which follow the principles of given by Mendel on pea plants. The same are applied to our monogenic disorders almost in 100% way. And this has made the diagnosis of all rare diseases a very, very easy thing. So just an interesting fact that 2022 was 200th birth anniversary of Gregor Mendel, and Austria, they took his DNA from his grave and sequenced his genome and compared it to the genome of which there was a hair on his Bible which he used to read. And they compared the DNA with that and found out it was his hair. And now they are analyzing the data. Just an interesting thing. So over those years, now we are really every day using those sequencing ourselves, and really very, very helpful. So coming to how to look at these results of next generation sequencing. Again, taking our example of our osteogenesis imperfecta, when we sequenced 86 children with osteogenesis imperfecta, our diagnostic yield was about 87%. And out of them, 2-3 cases were of some similar disorder, but not osteogenesis imperfecta. And here you can see these are the autosomal dominant disorders, autosomal dominant genes for OI. And here many of the variants are known. While autosomal recessive osteogenesis imperfecta, other countries report it as only 20%. Because we have a lot of inbreeding and maybe consanguinity, our 40% cases of OI are because of autosomal recessive genes, and there the risk of recurrence in the family is 25%. And out of them, 75% variants are novel in the various genes. So once you don't know that, novel means that variant is not reported in any normal individual in a population, or it is also not reported in any patient with osteogenesis imperfecta. So how we decide whether it is causing disease or not? Because the reference genome what we have, it has very little, the databases have very little representation of Asians and Indians. So naturally, this is a challenge. And here you also have to know some things like integrated genomic viewer. So what I picture showed you, these are IGV pictures where you can see the sequences. Rather than seeing a Sanger sequencing, you see the sequence in IGV, integrated genomic viewer. And then also reports say GRCH38, GRCH37. These are reference genomes. So naturally GRCH38 is the latest one and it has more information, and some nucleotides which had different number in GRCH37 may have different number in GRCH38, and that may cause some confusion if you are reviewing the literature. So what you see in this integrated genomic viewer, that at this particular point, the normal sequence is GA. So here GA is inserted by T and replaced by TT, and it is happening in all the reads. So if this region is covered maybe 100 times, every time it is the same. It means that there are both copies of the gene have the same sequence, TT, replacing GA. So this is really homozygous. And then here, if you see in this particular gene, you can see that this particular region is sequenced 307 times. And out of them, 46% times there is A and 54% time there is G. So it means about 50-50 ratio. So this is heterozygous, and there is one sequence as A and normally G. So normal G is replaced by A in only one allele. So if this gene causes dominant disorder, the person individual will have the disease. For autosomal recessive, so this is heterozygous. But when we say that heterozygous, but there could be another mutation somewhere else. So here in this case, spondyloepiphyseal dysplasia, it's autosomal recessive. And that individual has two sequence variations, and for both of them, he is heterozygous. So how do we know whether both the sequence variations are on the same copy of the gene, or one is inherited from father and one from mother? There you have to only do by sequencing parents, and one parent is heterozygous for one mutation, other is for the other. So this is a deletion. So in case of deletion, you don't see deletion, but after deletion, you see such type of cluttering, while for point mutation, you see such type of heterozygous. So basically what is happening, the mutation inherited from father and one from inherited from mother are different. And particularly what we call this individual is a compound heterozygous. Normally, we always use homozygous as a word, but really many of the cases are compound heterozygotes. Then these compound heterozygotes sometimes in NGS can be seen and definitely confirmed, because if the variations are very nearby. So if they are so close that during sequencing, they are sequenced in one segment. So what is happening? This particular patient, there is a 5 base pair insertion. So this purple are the 5 base insertion. So some of the reads have this, and everybody also has some again C at the nearby point. So it means that these two variations are nearby. So this is C is just a polymorphism, but by chance we can show you that if both of them are nearby on the same copy of the allele inherited from the same parent, they will be always on the same read, same fragment. While the others in between, you can see there is a nearby, again C to T change. So there is heterozygous for T, and this is also same. So this is happening. This we know that it is on one read and this is on the other read. So they are from different parents. So this is really a compound heterozygote. But most of the times the two variations in the person would not be so close by, and you will always have to do preferably parents, so that if you do NGS and parents and child, then together you can make diagnosis. Then the power of this next generation sequencing we have seen. But here you can see this particular case, again osteogenesis imperfecta, and there was a deletion of 12 bases. You can see this deletion here, obviously. Sometimes it's very difficult, but nowadays even their algorithms can identify, and we were looking for osteogenesis imperfecta genes, so naturally we can open IGV and look for each gene by gene rather than going into the software or algorithm. But it's heterozygous. But we know that WNT gene is a autosomal recessive gene, and this family is consanguineous family. So what is the inference? the person should be homozygous. There should be both alleles from the parents should be the same. So what we did Sanger sequencing and found that the person is homozygous and the pair, one of the like their parents were heterozygous for the same deletion. It means that sometimes in exome sequencing you can miss some things, and this specially happened because there is a high GC reach region. So in such situation, there may be such type of false calls giving a homozygous person to look like heterozygous. So with this, we saw that you can see the variations. Now we have to see whether it's a benign variation or pathogenic. And pathogenic, by pathogenic means that almost 99% variations which are labeled as pathogenic are disease causing, or they are damaging the function of the gene. While likely pathogenic, in many reports you get likely pathogenic, means 90% of those variations. This is just an estimate. So it's because they have followed and found out that some likely pathogenic variants, later on there is information and they are turned out to be VOUS or benign. Same way, some benign variations, rarely likely benign, may be really disease causing, but we don't have evidence at this point to label them as disease causing. So you have to separate them into benign, VOS and pathogenic. So most important message is any irreversible decision should not be based on the variation of unknown significance. If you get VOUS and feel looks like biotinidase deficiency, give biotin which is harmless, that you can do. But based on VOUS, you cannot offer family prenatal diagnosis and termination if the fetus has the same VOUS. But so many times, other than all these information, you have to apply your mind and see whether how to classify these variations. So first important thing is if these variations are reported many times is most important, and there should be sometimes like glycine, all col1A1. There is a triplet of these peptides, and here you know that every third is glycine. And glycine is very important. If it is replaced by a bulky amino acid, then it causes problem in that triple helix formation and it will be damaging. So any variation in the glycine residue or any variation which is reported will be considered as pathogenic or likely pathogenic. So the flow of analysis of the data is that you find out all variations, then remove the variations from the normal, which are reported in the normal population. And for normal population, now you use the data of NOMAD. Then we may have your own in-house variations in Indian. Then you find out which are exonic variations. So that's why you keep on reducing the number and to find out which are likely to be. Then you work on them, whether your hypothesis is dominant or recessive disorder, and then you can come to one conclusion. So now this variation, we in SERPIN-F1 gene, we feel that this is causative for osteogenesis imperfecta in this patient. But this is not reported in any population. So you see, these are the softwares. We give information whether they are likely to be damaging. That means they just calculate and find out the importance of that particular nucleotide. And if that nucleotide appears to be very important because it is there in all species, and that means it is important. So these are various bioinformatic tools which will calculate and give you estimate. Always remember that these are estimates and not definitely pathogenic. And for all these are combined together now in a called as a Reveal tool. So Reveal score is very important, and you will see there's red are disease causing variations, and most of them would have a very high Reveal score. But of course there will be some with low. So just to tell you that not every scoring system is foolproof. So they will have some limitations. And then we come to these guidelines. So how to use this information and make conclusion whether the variant is a likely pathogenic or benign or pathogenic. For that, American College of Medical Genetics and Genomics made criteria. And these are the various criteria. And you need to at least read once this paper. It's not necessary you have to do everything. But the point to stress is that some like diseases, like loss of function, if if you know that mucopolysaccharidosis, the enzyme is deficient. So any variation which will change the gene and make it stop codon. So loss of function variants will be always harmful. So you can see then you give it is a very high score as PVS1. Then sometimes these variations are very high, many times reported in the patient population. That is very, very important thing to support pathogenic nature of the variant. So there are many such, it can be change in the multiple computational tools. As I said, computational data, it is on the lower side. The support of these particular computational tools result. So if it says damaging, doesn't mean always damaging. So it is of a lower, it's a supporting criteria and not a strong criteria. So there were some things like this. Again, segregation in the family. So many times there is only one individual in the affected, but not many. But if there are 4 individuals in the family, 3 have a disease, 1 does not have disease. So the variant is present in all 3 of them and absent in the one. So that supports very strongly that this is really going to be disease causing. So the strength of co-segregation will keep on increasing as you get more number of individuals. Then there are some things like reputable sources have they reported. So this is also, you can see it's a lower score because it doesn't mean we report once and then it is there. After that, many people saw in normal population, but it is there in the database called CleanVar. And then it remains there and other people also will keep on repeat. So the false thing will get on purpose, propagating. So don't think that everybody once reported. So but if it is repeated 15 times, 10 times, it's very likely to be important. So same way, patient phenotype matches. So if in osteogenesis imperfecta, if there are 20 genes, I will get some variation somewhere. So you cannot say ki osteogenesis imperfecta ka gene hai, I know this is osteogenesis. But you don't know this is phenotype of osteogenesis imperfecta because of lepre gene. So there is nothing specific, all are same. But if type 5 osteogenesis imperfecta, there is ossification of intraosseous membrane and hyperplastic callus. So that is a characteristic phenotype. So if you get a mutation, by the way, most of the patients have only single mutation because it's a gain, probably some gain of function. So then you can use this. Otherwise, if you say intellectual disability, there are 1,000 genes and you'll get something. So just labeling that this is the causative. Like in case of immunodeficiency disorder, so many genes are there. You will get some variation somewhere. So you cannot use matching the phenotype for that. And if it says that immunodeficiency with hypoplastic nails with hair abnormality, then probably that is a very characteristic phenotype where you can use this particular criteria as matches the phenotype. Otherwise, if you don't use liberally. So for doing all this, you have to use these databases like Nomad, where there are more than 7 lakh exome data and almost 8 lakh of data is there. But you see, Asians are represented very less. Then there are databases of mutations. Then there is a CleanVar, which is a database again of mutations, but it is not cleaned by people. Just people keep on adding. So that is not really, somebody doesn't verify or validate it. So you have to really look at it, but you have to make your impressions. Then what I showed you and what we did can be together done by a website called Franklin. It takes all data from different places and then uses it. So one example for that I would like to show that this is a DSD case, female with XX karyotype, and isko kaise hatao ye ke more. So here there is one gene which is for XX reversal. So karyotype of this girl was XY. So naturally this is unlikely to be the causative gene. And then it is also present in so many, at least some individuals in the normal population, but there is also one entry of pathogenic in case of CleanVar, but that entry has congenital heart defect, doesn't match with our phenotype. And when I personally went to Nomad and saw that there are 26 individuals with the same allele, And then some of them are also XX and XY. So XY by XX females with this particular mutation are known. So they are normal. So this is unlikely to be disease causing. While this particular variation in DHX37, this is a missense variation. It's for 46XY sex reversal, which matches, and it's absent in the population database. And it was de novo. That means both the parents did not have. So this is very important. And one important publication is there. But if there is only one publication, you should see the publication and find out. So this particular publication, what they have shown is that this particular variation decreases the protein as well as decreases the mRNA. So that means this is real. This variation is really causing lack of function to that particular. And this particular family was, there were two in males, one reared as female, had this variation. And also there were other females who also had variations, but not, they were normal. So it is sex limited phenotype. And this much of information with de novo, we can think that this is a disease causing variation. So there was no risk of recurrence, hardly any, but family's assurance. Last week we did prenatal diagnosis. So in Franklin, as I said, you can put these variations and it will give you idea whether it's a pathogenic or not. And then the other variations, so it's a synonymous variation, but it creates splicing sites. So it really causes damage to the gene function. And then because of this, it is becoming variations towards likely pathogenic. So these type of things, and there is a possibility of modification. If you can add whether the phenotype matches. So it can be supporting phenotype, moderately or very strong phenotype, which I discussed beforehand. In case of osteogenesis imperfecta, you cannot say it's very strong phenotype matches. It can be moderate. So by using that, our own addition to this data, you can change the pathogenic nature of that particular variation. These variations are also reported sometimes in OMIM, and you can see that. So some change in at your level, because you are seeing the patient, you can little make change in the pathogenic nature. So in Franklin, if you go to that website, you will also get small write-up about my story. And just yesterday I was putting snapshot I saw, so I thought of sharing. These type of these can be you can use and apply. So more and more, all databases, more and more you use, you become friendly, and then you can make the best use of them. There is another called Varsam, and where there also you can find out the same variation in silico pathogenic in showing pathogenic strong. So these various tools you should use to make your diagnosis. And while sending samples, remember that if you can give the laboratory these HPO terms, that will be very, very useful. And these are important for computerization. So again, as this is a summary, how you analyze the variants and find out the important variant, which is very, very important for your case. And it's like a strategy to find a needle in the haystack. And many of Indian variants are still novel. So because we have limited data of Indian variants. And now every time it's whether you do exome sequencing or clinical first. So there is a fashion in many conferences, clinical first or exome first. And there I would like to say, exome cannot be the only first, but it has to be in the early course of the disease. And this case, when this Pragya was here and was admitted with as diabetes, but probably turned out to be a pyruvate carboxylase deficiency. So especially in ICU babies, NICU or pediatric ICU, if you can send exome as early as possible, you may get diagnosis which can change the life. It can be really give you cure, or sometimes you know that this is a very serious disorder and parents can be given prognosis that nothing much can be done. So rarely something is not so easy. Here the father has a mutation, absolutely normal. The child had neonatal hypoglycemia and hyperinsulinemia. So he probably had a somatic mutation, giving rise to insulin secreting nodule in the pancreas. So a lot of interesting cases do emerge from that. And many times we could identify a novel causative gene for skeletal dysplasias and so many other things. So all this is all for prenatal genetic counseling. And lastly, I would end by saying this we have written under heart to heart talk, balancing the sweetness of family between monogenic hypoglycemia and multifactorial hyperglycemia. So this 20-year-old boy diagnosed with GSD3, parents were so terrified that they kept on terminating pregnancies for the fear of having another child with the same disorder. But finally, they took some himmat karke, then they had the choice, a girl who was normal. And then by chance at 7 years, she developed diabetes. So they were really terrified. And then they came to us. We thought they are in their late 40s and not thinking of any further children. So we had a lot of discussion. This boy wanted to be a doctor. I said, better do B Farm and do you look after your father's shop, less effort. And there are a lot of things. But finally, they were adjusted. They were happy. They were not very anxious now. But when I asked, do they want to know anything else? Then they said, we are really worried and we want to have one child without both the diseases. So they wanted prenatal. We were very happy. GSD ke liye to prenatal we can do easily. But for diabetes, we said we cannot give prenatal. But risk of recurrence is very less, especially at younger age. With age, it may. So finally, what I want to summarize that all these patients, they may come to you for diagnosis and treatment, and some of course nowadays do come for genetic counseling, but the genetic counseling has to be an important part of your management of these patients where you suspect or diagnose monogenic disorders. So thank you very much. And all these type of disorders, all these review articles are there in our genetic clinics, and all of you are welcome to become member of our Indian Academy of Medical Genetics so that you can get this publication, which from next year will be published by Kluwer Walters. So all these issues are available free online. And there is also an option of case for opinion. You can submit case for opinion like a phone a friend, and at least those with skeletal dysplasias, we may be sometimes able to help. Thank you very much.